In this presentation, I will be covering the basics of radial access. So, as an introduction, this endovascular procedures develop as a procedure with very less invasiveness when compared to the other type of vascular intervention, and it was initially adopted by cardiologists, and later the peripheral intervention and neurointervention came, of which the femoral axis was the most preferred axis since the emergence of the whole endovascular field. And the reason for opting femoral artery was the larger caliber of this superficial femoral artery and the hemostasis, which can be attained by pressing the femoral head against the head of femoral head to prevent any bleeding or hematoma. So this was the most commonly accessed vessel, and still this vessel has got many problems. The main thing is the access site complications, which can sometimes become very severe, which includes large hematomas, pseudoaneurysm. These two are the main concerns, and also the retroperitoneal hematomas, which is a nightmare in this scenario, which is catastrophic, and patient's symptom will be vague, like lightheadedness, tiredness, sweating, tachycardia, and altered sensorium, or just paleness. So how much bleeding is there, and when it started, we won't be having any idea till we see retroperitoneal bleed in CT scan. So that is a nightmare of femoral puncture, and moreover, it is an end artery, and there is no much collaterals or other supporting vessel which supplies the lower limb. So whenever there is a thrombosis or any sort of occlusion, it can be life-threatening or limb-threatening. Now, what are the main advantage of radial access? The main advantage is that it is superficial and it is easily compressed against the distal radius. So there is a very less space between the skin and the bone and the vessel. There is very less soft tissue. So the compression is very easy. And since the size of the vessel is small and the area is small, the hematoma will be small. And this hematoma can be easily identified. And most often patient will identify before the doctor, unlike a femoral hematoma, where the patient will be having just pain or vague symptoms. And there are collaterals to the distal circulation, especially the palmar arch. The palmar arch are two in number, the superficial palmar arch and deep palmar arch. So these palmar arch will supply the hand, collecting blood from both the ulnar and the radial arteries. And there are introsseous branches also, which contribute to the distal circulation. And whenever there is an occlusion of radial artery, it is usually clinically silent. And these smaller vessels sometimes act as anatomical sheath, just like our long sheath. These vessels, the calibrous vessel being small, may act as an anatomical sheath, especially when trying to cannulate vessels before reaching the arch of aorta. So these are the different types of arches. There sometimes the components will be missing, but usually both the SPM in superficial, DP and deep, both the superficial and the deep palmaras will be patent. So this is the main reason why a loss of radial artery may not be a catastrophic complication. So it is the American Heart Association which recommended the radial first initiative. So they started to get radial access before attempting the femoral access. So naturally, neurointerventional community is likely to follow, but there are certain factors which will make us reluctant to start off radial access. So coming to the radial, why radial when in relation with the safety factor, why it is more safe? So there are numerous studies. All these studies are done in relation with the coronary intervention, And from these studies, it is evident that it has got less access site complication as well as mortality. All these studies have huge number of patients being included. STEMI Radial had 700 patients, which has found that the major bleeding for transradial versus transfemoral is in the almost in the ratio of 1:6 with a p-value of 0.001. So it is very clinically significant and giving satisfying result, saying that the on-site complication as well as the outcome is better for radial access patients. In study in relation with neurointervention, Catapano et al. Has evaluated over thousands patients and found that transfemoral access has got 7% complication rate when opposed to 2% complication rate for transradial access. And it is almost identical to the previously done cardiac trials. Now, anatomical factors. There are certain anatomical factors where we think of radial access. One is aortic iliac disease, then severe arch tortuosity, where especially when we want to cannulate the posterior circulation. Then bovine arch configuration, where when we try to cannulate from the right radial axis, the wire, the catheter, whatever will be going directly to the left common carotid before reaching the arch of aorta, which is a major advantage. And about posterior circulation cannulation, which can be done from the ipsilateral side. Right vertebral artery can be cannulated from right radial, and left vertebral artery can be cannulated from the left subclavian while accessing the left radial artery. And from the patient perspective, the femoral femoral puncture is in a very unpleasant location since it is in the groin. It is not in the leg, and 2 to 6 hours of immobilization is not needed for radial, and the closure is very easy, and the compression is not cumbersome. The patient may have to lie down with a man on his hip compressing for almost 15 to 20 minutes for getting a good hemostasis. And the duration of the tight dressing and band is very less for radial access. When we think of radial access, all these should be coming to our mind when we should consider other approach other than radial access. Whenever the patient is having a low height, then anatomical abnormalities like arterial lusoria, then ulnar occlusion, so that if we can occlude the radial artery, which may lead on to hand ischemia, then upper limb atherosclerosis, then severe vasculitis, then any known disease of brachial, axillary, subclavian, or innominate arteries, prior radial grafting, and severe lymphedema of that particular limb, then potential site for fistula for dialysis, then patient with a lima percutaneous intervention, and for sheath, which is usually larger than 8 French, radial is not good. Most of the points are taken from this textbook, Radial Access for Neurointervention. And this presentation will be covering the basics of the radial access and some of the point in relevance to the neurointervention. Coming to the setup of radial access, and most of the time we will be accessing the right radial artery, and the preoperative area will be applied with 2.5 lidocaine or prilocaine topical cream covered by a adhesive dressing, so that the puncture site will the skin will be adequately anesthetized. And we should consider both proximal and distal access sites depending upon our experience. If you are starting off with a radial, better to do proximal, but at the same time we can try distal access also. Pulse oximeter, if kept in the ipsilateral limb, is a very good step, so that we can assess the limb perfusion. And a support band inferior to the hand, next to the knee, and avoiding free space distal to the hand is a good position. There are two types of position being adopted. One position is supinated forearm with the support below the forearm with the wrist extended, and the puncturing at a side, one finger proximal to the radius salute. Or we can put a padding underneath the arm right to the distal fingertips, like a flat platform, so that the hand will be lying very near to the patient in level with the hip. So overall position will be just looking like an axis, like a superficial femoral artery axis. This is the first type of axis, so that the arm will be a little bit abducted with the support under the wrist and the forearm. But the thing is, if the upper limb is more near to the patient, we will be more comfortable with the long catheters and wires towards our right side. And after accessing, for taking the angio of the hand, we can rotate the table 5 to 10 degree towards our side to bring the elbow into view. And sometimes we have to go for left radial axis in specific indication, and sometimes when the right upper limb cannot be used. Left radial axis is less accessed when compared to cardiology procedures, and main indication is posterior circulation with the hypoplastic right vertebral artery. So that we are planning to cannulate the left vertebral artery specifically, so that it is easy to approach from left to radial side. And after puncturing, the hand is pulled through the left femoral opening in the drape, so that hand will be coming just in front of the groin region, and hand is kept in midline with the elbow slightly bent. This is usually we can come here and puncture, and while accessing you can go to the right side, and the upper limb can be kept here. In this case we managed to do from this side, but it is very difficult, so that 2 persons are needed to hold the catheters and wires. This is almost the position I have mentioned right now. So the upper limb will be in the midline, and for left side it is better to get an anatomical snuffbox approach, because it is difficult to make this hand in a supine position, so that the tension in the limb will be less if we approach through a distal radial axis. Now accessing, it is 1 to 2 centimeter proximal to the crease, and in case of spasm we can move a little bit higher or lower, but more proximal will result in puncturing the radial artery underneath the brachioradialis muscle, and more compression will be needed and more chance for hematoma. That is a problem with going more proximal. More distal, the radial artery will be having less caliber, and vessel will be curving towards the anatomical snuff box, and sometimes may not be straight, it may be tortuous. So these are the two sides. This is the proximal, and this is the distal. Distal is otherwise known as anatomical snuff box. These are the boundaries of anatomical snuff box. We have extensor pollicis brevis and abductor pollicis brevis on one side, and Here, extensor pollicis is longest on the other side, and in between you can see in the floor you can see the radial artery. And why it is safer is because you can see here that this is the distal radial artery, and you can see that branches coming off proximally, so that if we are going to damage this artery, there is other way the perfusion of the hand is maintained, so that the distal approach is more safer than proximal approach. So there are so many difference. Analyzing through that, the success rate is almost no different, and crossing over no difference, and efficiency, the time to obtain the access, difficulty to obtain access, and ability to insert larger sheath is more in favor of approaching proximal, and hemostasis is almost comparable, and ease of navigation, proximal is better, and comfort on the right side, there is slight advantage for distal, but on the left side there is huge advantage for using the distal radial access. And complication, distal radial, all sort of complication is having a better advantage for distal radial access. Compartment syndrome as well as hand ischemia is very less for distal access. Now we have applied the topical anesthetic. Then we will palpate the right radial pulse. And while palpation, it is actually Allen stress is not actually needed, because finding decreased perfusion through the ulnar by Allen test has not found to be statistically significant, is not related to statistically significant favorable outcome in any of the procedures. So that doing that procedure is got no benefit for the patient. Even then, if you want to know how it is done, we can elevate the hand and make a fist for 30 seconds, apply pressure on both radial and ulnar arteries, then in a still elevated posture, open hand, and ulnar pressure is released, and if the color returns in 7 seconds, means the ulnar is patent. And while accessing radial, especially initial part of your career, always make use of ultrasound guidance, especially the distal access. Here we can see the radial artery. It is round and it is less collapsible when compared to the veins, and this should be the correct method to hold the ultrasound probe. And we can see the depth, we can see the size, and we can confirm whether it is artery by checking the color Doppler. And considering the size, in men the size is 2.6 plus or minus 0.4 millimeters, women 2.43 plus or minus 0.38, and when measured 2.3 millimeter is consistent with the outer diameter of 5 French, and which comes in 17% of individuals. And most commonly 3/4 of the individuals will have a diameter corresponding to the 7th fringe, outer diameter of 7th fringe. So most of the patient will tolerate a 7th fringe sheath or a 7th fringe direct catheter. This is the color Doppler of the radial artery. Red color means the blood is flowing towards us. Next is providing 1 cc of lidocaine for puncture. This is how we puncture. There are so many methods. Either we can make use of the 3-finger technique, where 1 finger is for palpation, 1 finger is for occluding the distal vessel, and 1 finger for palpating the puncture site. And or you can puncture like this. Always puncture at a 45-degree angle with the bevel up. And there are two methods. Front wall stick is the method which we use for femoral access and also sometimes radial access. And double wall through and through stick, or we can say counter puncture technique, is a commonly used technique for radial puncture, because the radial artery is having a small caliber. Usually 20 gauge needle is used, double wall puncture technique, and the apparatus will be a hollow needle inside an angiocatheter. So this is the needle inside a angiocatheter. This part will be removed initially. Then puncture is taken at a 45-degree angle. Then a small flash of blood will come into the hub of the needle. Then after seeing this, we know that we have punctured the artery. Then we have to cross puncture by advancing the needle further across the artery. Then remove the inner needle. Then very slowly withdraw the outer cannula until the gush of blood comes out. If pulsated gush is seen, wire is inserted. The wire will be a short thermo wire, and it is inserted only when the gush of blood is seen. And during this procedure, the angle of the cannula may be further decreased so that it is more in line with the artery. And while withdrawing the needle to get the gush, the wire may be held very near to the hub so that we can easily introduce the wire. The wire used will be a 025 hydrophilic wire. And what if the gush is not seen? The advancement is not recommended, because it is only when the gush is seen we can make sure that the tip is inside the lumen of the vessel. So even though the wire may go inside with the moderate resistance, this advancement stops after 1 or 2 centimeters. It definitely means that we are not in the lumen, but probably in the adventitia or outside the vessel. And it can cause vasospasm and arterial dissection. And in this case, we can make use of ultrasound, fluoroscopy, etc. And the tip will be straight if it is intraluminal. So if the tip is like this, then always reconsider the situation and never push hard. Try to change the angulation, try to extend the wrist, or take another puncture, or remove the wire, put the needle back in, once again counter puncture, and do the step once again, or take the puncture altogether once again. And further advancement also need a fluoroscopic guidance, because smaller branches will be there, so that the wire, if is going to the smaller branch, can induce spasm as well as leak and hematoma, so that we should always see a straight tip of the wire to go further. And while introducing the wire, always make sure that we are not introducing the wire so much so that it won't go and hit and cause spasm. This is due to the wire, the tip of the wire causing spasm, and after administration of NTG, the spasm has relieved. And the section of the wire longer than the length of the sheath should be outside the skin, so that once we introduce the sheath, the ample length of wire is remaining outside the sheath. And there is a huge advantage of double wall puncture, because it is a small artery, and first pass cannulation which is very important, will be high in case of counter wall technique. Then during puncture, sometimes it may be unable to visualize the needle, so that you have to check the needle entry point, and angulation should be done. Then especially during ultrasonography and What will be the reason for failure of puncture? It may be due to a small radial artery, or it may be a spasm, or it may be due to occlusion. Now, after the guide wire is inserted, put a nick which in a parallel to the wire. It is not horizontal; it should be parallel. Now the sheath is inserted over the guide wire. This is how sheath is inserted. Try to hold as on this end, and always make sure that the wire is outside the sheath. And this vascular sheath, radial vascular sheath, are newer vascular sheath, and it different from femoral in such a way that it has got more inner diameter than expected, and it is only 0.12 mm thickness rather than 0.02 mm thickness of standard sheath. And 6 French sheath has got a 6 French inner diameter, but maintains same outer diameter of that of a 5 French sheath. That is the advantage of being having a thin wall for the sheath. And for diagnostic angiography, we usually use 5 French sheath, and for procedures we can go up to 7 French sheath. The thermoslender sheath are available in 10 or 16 centimeter length. Merit radial sheath are available in 7, 11, 23 centimeter length. And longer slender sheath are beneficial in diminishing repetitive friction of catheter movement against the radial artery, which can cause radial artery spasm. So, if you are using a longer sheath, the constant friction of the catheter against the radial artery will not be there. And initially start with the short sheath and do a check angiogram and assess the size of the artery. Then exchange with a large sheath if you are planning to put a larger sheath. And longer. So this is the concept of a thin wall. Here we can see a large catheter with inner diameter 2.46. Here we can see a small catheter having a small thinned wall with a same inner diameter. Example of 4-inch introducer set, which is having introducer and the sheath, the wire, and the needle. And sometimes we can make use of the fluoroscopy to visualize the sheath. And after sheath insertion, we have to flush the sheath and we have to give vasodilators. Unlike the femoral puncture technique, where we need not use a vasodilator, we have to use a nitroglycerin 100 microgram, which we usually use. And on top of that, verapamil 2.5 milligram can also be used. And nicardipine is the other medication which can be used. And we may warn the patient about a burning sensation which can happen during injection. Along with that, heparin is also given, and at an amount 50 units per kg, up to 5,000. So this is at our institution giving local anesthetic, and after adequate anesthesia, we are palpating for the pulse and putting the puncturing the radial site at a 45-degree angle, and we are removing the, once we are seeing the flash of blood, we are removing the needle and withdrawing the cannula back, and the wire is kept very near to the hub. And once we start to see gush of blood, we can introduce the wire. So first tripling is there, then gush of blood comes, then we can enter. And only a sufficient amount of wire should be introduced inside. And we can remove the cannula. And from the other end, we can put the sheath. putting nick at the skin. So rest is the same as of the femoral axis, and always try to do an angiogram of the arm, and we can see radial abnormality up to 10%, and always take a road map while negotiating through the radial artery, which will help us to see the ulnar patency, can identify radial artery anomalies, loops, high bifurcation, etc., and avoids cannulating smaller branches and reduces spasm of the radial artery. So this sort of abnormalities can be seen, but carefully negotiating wire through the artery will eventually straighten up the vessel. So we are negotiating wire. We are taking a smaller wire for this radial artery, so that the artery gets straightened up, and we can introduce the catheter over the wire. So briefly going to the vascular anomalies. Vascular anomalies are identified up to 22%, and of these patients with vascular anomalies, the success rate of procedure goes from 98% to 91%. Most common is high radial artery takeoff. That means the lower caliber of the artery will be there up to a higher up level, like where the artery femoral artery bifurcation, the brachial artery bifurcation is in the mid-arm level, and in which there is more chance for vasospasm, but tortuosity is less common. Then next is a radial artery loop. It is coming to around 2%. It may be simple or complex loop, and most of the time recurrent smaller radial arteries will be arising from the loop, which will be connecting up to the proximal vasculature. So wire may have to go through the loop, enter the recurrent artery, which is having a straight course thereafter. So this is the loop, and after that a smaller artery will be going up. So we have to cannulate all we have to take the loop and go up through the smaller artery, for which the soft J tips will help to go through the you have to make use of these angled tip and J tipped wires for negotiating through that. This is a classical example of a patient who is having a loop. After cannulating, it get straightened up. And tortuosity, it may be a alpha type, it may be omega type, or it may be a Z pattern, or it may be a S pattern. So and it comes to around 15%. This is once again a tortuosity in the proximal radial artery, and after this wire is introduced carefully, it will get straightened up. So most of the anomalies will get straightened up if you carefully introduce the wire through that. And vasospasm is most often due to vigorous manipulation and errors in technique. And how to tackle is by using careful methods, like using ultrasound and using additional injections of NTG and verapamil, and having a longer sheath. And other anomalies like hypoplasia, focal stenosis, atherosclerosis, which may result in changeover to femoral axis. Then anatomical snuffbox approach, and it in the wrist, the radial artery lies over the radius, and the radial artery proceeds along the floor of the anatomical snuffbox, passing dorsally around the scaphoid and the anatomical snuffbox. That is very important. So that if we cause occlusion at that level, the distal, the palmar arch is not devoid of blood. So this is the area of interest. Before that, the palmar artery gives off the blood supply. And either side we have two tendons, and medially extensor pollicis longus, and laterally by combined two tendons, abductor pollicis longus and extensor pollicis brevis. And the distal artery, distal radial artery is having a little less caliber when compared to the proximal radial artery. Here is the site where we can palpate for the radial artery pulse or to do an ultrasound. What are the advantages? I have already mentioned, and it's more ergonomic and less complication, especially on access site complication. And technique is I have covered, like same topical cream, then hand being positioned lateral to the hip, then mild ulnar abduction, and on a plain platform you have to keep. Ultrasound is strongly recommended when compared to proximal. The distal radial access always use ultrasound. So this will be the ultrasound appearance. We will have the radial artery in the center with the two vessels, which will be veins and which are compressible, and extensor pollicis longus, extensor pollicis brevis, abductor pollicis longus. So this is the two boundaries, one here and here, and this is the floor. In the center of the floor, we can have we will get a radial artery, and always put a color doppel to confirm the radial artery. And we can move the probe from distal to proximal. First, we will identify two metacarpals, this metacarpal and this metacarpal. Then we'll be moving back, and we will identify the head of the two metacarpals. Then we will identify two bones. In between the two bones, we'll be having finally getting this configuration. And the direction will be of more medial while puncturing, and we can make use of a distal zinc closure band after the puncture, and the compression needed for hemostasis is minimum. And yes, this is the hemostatic band used for anatomical stuff box. How it is applied is we will inflate till the blood is not coming out. Then we will deflate, and we will see some oozing of blood. Then we will once again inject a very little amount. Then what are the main disadvantage of distal access? One is learning curve, so that the initial phase up to 10% of conversion rate will be there, but eventually the conversion rate decreases, and it is almost similar to the other proximal access. And in neurointervention in radial access, about patient selection in neurointervention, clinical features that favor transradial access is in a patient who is likely to have more access site complication, like an obese patient, a patient who is having bleeding diastasis, who is taking anticoagulation, antiplatelet, and having a distal extremity occlusive disease, and high DVT risk, because femoral access will make the patient immobile for some time. Then patient having low backache, and in a pregnant patient where radiation, this abdomen, groin area, etc., can be shielded while operating in the upper limb. So these patients, this is how patients are selected. And if the patient is having Raynaud's phenomenon, reflex sympathetic dystrophy, ipsilateral AV fistula, and severe trauma, etc., we can consider do not favor transradial access. And anatomical factors, if you are trying to access the posterior circulation alone, we can make use of transradial access, without arch being manipulated, so that the embolic complication is very less. And also patient with the bovine arch, which I already have mentioned. And choice of gate catheter and transradial sheath. It depends upon the radial artery diameter, type of the intervention needed, so that the diagnostic is for 5 French, and procedures will be 6 French, 7 French, and what is the target artery. If we are trying to cannulate the vertebral artery alone, we can make use of catheters like Bren or any other right angle catheter. And if we are going for cannulating the arch, we can make use of SIM2, SIM1 catheter initially. And if it is not working only, we can go for other catheters. And about radial artery diameter, if the if the radial artery is small, there is more chance for occlusion, then more chance for entrapment of catheter due to spasm. And if the preservation of parent artery for further use is more important than avoiding hand ischemia, then always consider the diameter of the radial artery. Then about the target artery and aortic arch anatomy, I have already mentioned about all these things like vertebral artery, tri-ipsilateral radial, and bovine arch, transradial, then a tortuous arch anatomy. So all these factors, we have an upper hand in using transradial. And about case selection for transradial approach, always start with the diagnostic angiograms, then go for elective procedures, posterior circulation access initially, and procedures that require less support should be done first, like proximal carotid. Then procedures involving external carotid artery, and then go for intracranial procedures, and then go for emergency procedures. Okay. So it is set like only after 100 radial artery access, go for emergency procedures. Then about intervention specific, all sorts of intervention can be done through transradial, and procedures can carry which needed less support can be completed using 6 French, and more support will need higher French catheter. And also distal access catheters need to be used. So the combination of the distal access and the gate catheters will be slightly different from the femoral one. For example, we usually make use of Envoy 6F catheters, which will not allow larger distal access catheters, or even Catalyst 5 or Navian 5. You have to use Fubiki 043 instead of 5 French distal access catheters. And about the technical difficulty, if there is a difficulty to advance gate catheter over diagnostic catheter, and wire resulting in herniation, one of the method is wire is to be held placed distally into the ICA or ICA, depending upon the procedure. Then diagnostic catheter have to be placed opposite to the wall of the aortic arch, and long stiff wire may be used. Then whenever there is difficulty to advance into posterior circulation, it may be due to high angulation, and for that we can make use of micro catheter and micro wire to navigate to the acute angle. And when to change over to femoral, procedure not completed even when utilizing recommended hardwares, and a crossover rate is 5 to 10%. Whatever be the experience, it will be around 1 to 5%, and for a beginner it will be around 10%. In our experience, last 2 months, in August, we have this is only the diagnostic angiograms, not including the procedures. Initially in August, we did the 22 radial and 2 femoral, considering the anatomic, considering the anatomic factors, and 2 cases have to be changed to the femoral from radial access. But eventually, in later months in September and October, not even 1 case we have changed over to femoral. So that's how we can improve. Thank you, sir.
All right. So the left radial positioning, is that actually from the book or from your institute?
One positioning is from my institute, sir, because the patient was not comfortable to bring the left upper limb to the front. So we just completed while standing on the left side itself.
Sure. For me, like it's always easier, to lean from the right side onto the left side and then access. That's one thing. The angiocath you mentioned, we call it Jelco in India, I guess. Okay. But otherwise, it's a good basics overview. What other cases have you been doing intervention-wise?
Sir, external carotid artery intervention like MMA we are doing. Then only 1 thrombectomy and 1 intracranial stenting through radial. And all MMA procedures are done through radial, and all the diagnostic.
Yeah, it's always easier to start with right carotid interventions and then bovine left carotid. Afterwards, non-bovine left carotid comes into play. I think that's the progression. Yeah, nice presentation.
Thank you, sir.
Any other questions? Oh, Dr. Karaprakash is here. Hello,
I don't do this. And we have Rakesh who works with me, I've done some. So I personally have very little to add to what you. Obviously, your presentation was very good, and I think you have covered everything that needs to be covered. So I think you've done a good job, Jayasankar.
Any other questions? No.
No, I don't think so. Okay, I think you've done a very good job there.
Sir, voice is not clear, sir.
Can you hear me?
Yes, I can hear, but the voice is not clear, sir.
Should be okay. I can hear you very clearly. Anyway, then I think I really have to add. Yeah. Good. So next week, Kalyan can show us some cases that he does through the radial.
Carotid, yeah, carotid.
Yes.
No. All right.
Thank you.
Thank you. All right.
Good night, sir. Thank you, sir.